Good afternoon. Welcome, everyone. We are pleased that you are joining us today as we explore how several health centers have deployed their workforce in response to the COVID-19 virus. We know things are especially hectic right now, and we appreciate you taking the time out of your schedules to join us. I'm Suzanne, Suzanne Spear, Director of Workforce Development here at ACU, and I'm going to be facilitating our call today. Before we get started, just a little bit about ACU, or the Association of Clinicians for the Underserved. We are a national membership organization founded over 20 years ago as an NHSC, or National Health Service Corps, alumni organization. And while we have changed a bit over the years, we remain committed to the health center workforce. We really focus on two main goals, and that's access to care and clinician support. And of course, recruitment and retention of a transdisciplinary team is the road to achieving those goals. We have many programs which you can read about on our main website, which is clinicians.org. But today I'm here with our national cooperative agreement, which is called the STAR Center. And ACU holds this national cooperative agreement from HRSA's Bureau of Primary Health Care. Our NCA is called the STAR Center, which stands for Solutions, Training, and Resources for Recruitment and Retention. Just as our name indicates, the STAR Center is your one-stop shop for free resources relating to the recruitment and retention of a health center workforce. Please go to our website at chcworkforce.org to take a look at all of our tools, resources, online courses, and much more. And remember, all of our resources are free. Just a few webinar housekeeping items before we get started today. The first one is we are recording. We will be posting the recording along with the slide deck on our website following the session. Second of all, ask questions. We welcome any and all questions you may have. We will have a Q&A session at the very end of today's time together. But feel free to ask them in the chat box as you think of them as all of the speakers go along. And finally, please complete the brief evaluation at the end of today's session. Your input and evaluation is definitely valuable to us. As I mentioned, if you have any questions, feel free to use the question and chat boxes as we go along. And if you're having any problems connecting or any other technical issues, feel free to email Mariah Blake at mblake@clinicians.org, and she will get you pointed in the right direction. We're grateful to have 3 health center leaders on the session today, sharing how they are managing their workforce efforts during the COVID-19 crisis. First, we have Kathy Brieger, Chief of Workforce Development at HRHCare in New York. Then we'll have Suzanne Lagarde, the Chief Executive Officer from Fairhaven Community Healthcare in Connecticut. And finally, we'll hear from Stephen Snyder from East Boston Neighborhood Health Center in Massachusetts. With that, kicking it off, I will hand it over to Kathy Brieger from HRHCare. Take it away, Kathy.
Thank you. So it's great to be here, although the topic, it's hopefully you'll all take away something and maybe we can learn things from each other. I'd like to have the first slide. We're going to talk a little bit about how kind of what's happened with the HRHCare and what, who we are. So we're a very large system. If you look at this, we have 42 health centers that span New York State, from the very rural areas up in Columbia County, and then we go all through all 5 boroughs of New York City, and then out to Long Island, all the way out to the tip of Long Island. So we serve quite a large number of patients, about 245,000. Special populations, you'll see agricultural workers, homeless, public housing, veterans, HIV, patients who are positive with HIV, as well as substance abuse disorder. We have day programs, we have really a large variety of things going on, and that has really impacted us as I go through some of the ways we've adjusted and continue to adjust with the health center. So if we go to the next slide, one of the things that we've been looking at, when this first began, we said, how do we do this? So we wanted to have a strategic response using all of our top people. So we have a leadership meeting every night at 5, and that really has everything from supplies, facilities, staff, HR, leadership of every kind is there. And we in the initial days, weeks, we actually planned how do we do everything from get the supplies we needed, strategize on staffing, and then looking at what the current state was. That was really the first phase. And the second phase now, moving to future planning, where first phase 1 was, looking at getting everything set for telemedicine and remote work. We now are fully in phase 2, maybe even phase 3, which was looking at staff and everything else that we had to do to make things happen. So on that, the next slide, during that strategic response, we have a presentation. Again, we follow everything with a smart sheet. And one of the things that we use is this Dr. McIntyre, who's our medical director, presents the data on how many cases in New York State, especially with a focus on how many people are in our area. So you'll see the counties to the left and the cases that have been reported. Next slide. The other thing she does is to look at, how many people we've tested ourselves by, and we're looking at race and ethnicity, which becomes really important. As we know, the health centers are at the very, very beginning of this work. We've been working with people around health disparities for our whole, from the time we were first formed. And so this becomes very important to track the numbers. And you'll see that, some of these especially impact New York State in a big way. The next slide. She also presents data on, this is a map of New York City and some of we wanted to look at how do our neighborhoods that we're serving look, and you can see a very large number of cases by zip code. And this is for New York City as well as the whole state. Next slide. This is no surprise to any of you, but for us, it really helps to track, who are we serving and how does this impact us? We also have at our nightly meeting a summary of how many people were tested, how many people were negative, positive, and then you can see those people who are waiting results. We also look at numbers of people tested per site. This helps us to know where do we need to put staffing and move people as needed. Next slide. So this is a big question. How has COVID impacted HRHCare? Well, like many of you, as this really escalates, we see the drop in visits from prenatal to regular primary care visits. People don't want to go out. They've been very concerned about contracting the COVID virus, and so the drop in visits. We also needed to look at moving people to remote work. Behavioral health was first, and this was an easy match, trying to get people connected. Unfortunately, we had issues around closure of some community partners, food pantries at first. Now they're starting to reopen. We had to figure out how to do our day programs because we have, especially in the city, a lot of programs serving people with substance abuse issues who are really in need of support. So we've had to really transition that, some of those programs. The shelters that we work with, many of them did not want outside partners coming in, so we've had to move to a medical van parked outside of some of the shelters and other things. Even in our rural areas where we've had to close one of our migrant centers and to reorient people to another health center, we also are mapping out plans to have our mobile health unit go to key areas. Of course, we're not immune to staff getting sick, and so some of the programs that we have assigned people to, when they get sick or unable to work, we have to move and have other people take in their place. So this has been a big moving thing. I think every night we get a report out on how many people are out with COVID. We actually, at this point, have people returning who were out on furlough and now are back. I'm sorry, who have been out with being sick with the COVID virus. We also, we've had most of the demand to move the our regular primary care visits to telemedicine. And I would say that this has been a major lift. There is not one staff member who has not been involved with this process. And I think, when the question came up, what was my role as either the chief workforce officer, I'd have to say that everyone was involved with all of these moves. Our COO was very much strategically involved with getting people from one position to move into another one. We had our one of our lead physicians who's involved with telemedicine and our chief medical officer all involved with moving visits to telemedicine. So it was quite a big lift. We had people who were involved with when the day programs had to close, we had to make sure that they had access to food. So that required another person in charge of health homes and other programs to get food to the people. We have farm workers in our area. We serve about 9,000 total. And in some of these areas, the farms are struggling because the kids are out from school and they're not able to leave their kids alone. So we have this secondary issue going on, which is our patients are not getting access to some basic needs that they have. Next slide. This is a photo of a couple of our staff members in the van. And again, we have a couple of mobile vans for each region, one out in Suffolk County and one in the city, in New York City, and then another one in the northern Hudson Valley area. And we found that with our move, and this is a learning situation, we're learning as we go, what kind of services are needed and how can we best strategically place ourselves to make sure that people are getting the service that they need. The mobile van has really been very, very helpful. We've also set up, not pictured here, but we've set up areas where people can go in drive-through testing, and we've done that in some strategic areas in the city and also in the Hudson Valley and in Suffolk County. As tests became more available, we were able to do this. And of course, it's a moving target about what we have available, but this is something that was really important to everybody in the community. So let's have the next slide, please. So what would I say when I look at this? And I think, again, I have to be honest and say that this was an effort that really involved so many people. It wasn't just me. We had to develop training modules that were specific to the job role. So weeks ago, we met with outreach teams and said, how are we going to move using the CDC guidelines? How do we move our outreach roles? How do we make sure we're protecting staff? How do we teach people how to work remotely? We've had a big lift of the chronic care management program, and we've moved some people who were clinical assistants or patient navigators into this role. So it's been, teaching people how to use technology, how to use Zoom, how to use Microsoft Teams. And then staff support for communication with, they have to really deliver some very difficult messages. So a lot of our training and our focus has also been how to work with difficult messages, using change management principles to really deliver these empathetic messages to people who are really suffering in a lot of ways. And then we're trying to support our staff through wellness. We have a colleague from Greene County, North Carolina, who's been giving us meditation courses. We offered a Spanish class also, which has over 65 participants. Even though it's Spanish, it's a way of just escaping from what's happening. The next slide, please. So I've talked a little bit about all of these things, and I'd say that helping people to face really how are we using telemedicine, teleconferencing, and remote work to support the work of the health center has impacted everything, everything from using Zoom to Microsoft and you know, changing how we outreach, changing how we're doing all these things. So the workforce, how the workforce looks now is so much different than what it was, you know, a month ago. And we continue to make these changes as we negotiate the, you know, the transition from being in a heightened state to maybe a more stable state. Next slide. I'd have to say, when we look at this, when we're looking at this movement, we also have to say, how do the teams change? Could we have the next slide, please? When we look at how does this look, some of the challenges, I think knowing how to use the technology, documentation is an ongoing issue. We need to make sure staff and patients are able to use the technology. We've even had things like office hours in addition to recorded trainings on Microsoft Teams and Zoom, office hours on how to use this. We've done modified shorts rounds and all of these other programs, and I think coding to make sure we're compliant with coding with all of the telemedicine, telephonic services. The biggest thing I'd have to say as a chief workforce officer has been the need to look at how do staff feel when they're being moved into different positions. This is a major change, and I think that trying to be as supportive as possible. I think we've offered training sometimes 3 or 4 times to make sure people got it. And I think this is all part of our mission or our purpose is to make sure people are really able to access this information. The next slide, please. I'd say with advice in closing, you know, how do we, in this situation, when you're faced with all of this, I think keeping, you know, the principles of change management, which are really using this planned communication strategies and making sure that we understand that the people side of change is of utmost importance. It's not just about getting the technology. It's not about telling people, you know, the production side of human resources. It's about how do we work through changes and change in a way that's going to be healthy and get us to the other end or the future state. We also want to provide staff multiple ways of learning about technology and changing workflows. Because we can't deliver in-person training anymore, making sure that we are as creative as possible. We use Zoom breakout rooms, for instance, to practice telephone role plays. And that was something new. I had to learn that technology, but I think it helps people to have that same practice that we might have done in live sessions. And lastly, I want to say that this COVID crisis has really impacted everyone from our staff. And while EAP is helpful, I think that we in this role in leadership need to offer staff and positions and staff and supervisor in a variety of ways all the support we can. And that includes things like our meditation class or like, and I want to even say something a little different. We actually offered homework help. We had students that were home from college that were students of their parents, of some staff members. And then we had students who were at home who didn't have their mother or father at home to help them with homework. So what we did was we actually created a Google, you know, using the Google platform, a way of being able to connect. And so we have a volunteer program with our staff and our staff's kids. So anything that we can do to help, I think that would be my advice to try to make that possible in that link. That's it for me.
Great. Thank you so much, Kathy. We really appreciate you sharing with everyone about how you've changed your workflows and how you're doing things differently now. Now we're going to hand it over to Suzanne Lagarde with Fairhaven Community Health Center. Suzanne, you can go ahead and take it away.
Thank you so much, Suzanne, and welcome to everybody who's on this webinar. I must say I'm thrilled to be able to connect with people. Our reality is so different these days, so even doing this via webinar is something that I've been looking very much forward to, so thank you. Next slide, please. So Fairhaven Community Healthcare is located in New Haven, Connecticut. We're a fairly small FQHC. We've been in operations for nearly 50 years and serve roughly 18,000 patients. We have a fairly large uninsured population, 23%, and most of those are uninsurable because of their immigration status. We run 13 sites, which include 6 school-based health centers, and over 70% of our patients are Hispanic, and a majority of those patients are monolingual in Spanish. Like most FQHCs, we provide the spectrum of primary care, behavioral health, substance use disorder treatment, dental and vision. And before COVID, we employed roughly 215 staff. Next slide, please. A little bit about COVID and New Haven, Connecticut. So in front of you, you have a map of the state of Connecticut. And if any of you have been following the news, which I suspect we're all sort of glued to, the hot spot in the epidemic in New York City, as well as New Rochelle, which is actually a suburb of New York, just to the east of New York, and actually just to the west of us. So we were part of that first wave that hit New Rochelle. And it's very interesting because we get these state documents from our state epidemiologists every day, and they're color-coded. And what we've been able to see is literally the COVID marching through our state from southeast to northwest. So you'll see that up in the northwest corner, I'm sorry, from southwest to northeast. You'll see that in the northeast corner, Wyndham, this is data as of Sunday, still had only 4 cases, whereas down in Fairfield County and New Haven County, where I am, we're cumulatively over 1,000 cases and quite a few deaths. And over the past few weeks, these numbers have just been progressively marching in that direction. Connecticut is a state of about 3.5 million individuals. As of Sunday, we had over 12,000 cases, and like everyone else, there is absolutely no question that this is a significant understatement, since testing is not easy to come by. And we have now over 600 confirmed deaths in the state of Connecticut. At our health center, although we're relatively small, as I said, 215 staff before COVID, we've had 12 confirmed cases among our staff. I can tell you that in the state of Connecticut, there have been 2 COVID-related deaths amongst staff of FQHCs, which I can't even fathom the tragedy of that. One of the 12 who were of our staff who were infected has been hospitalized and was actually in the hospital for over a week, but fortunately has gone home. So we're very happy about that. The impact on our staff has been substantial. The peak was when we had 42 staff out in one day, and that was a combination of sick or quarantine because of exposure to cases or suspected cases, and a small number were childcare issues. Amongst our patients, as of last Friday, we had tested 265, of which 98 were positive, for a positivity rate of about 37%. Next slide, please. So for us, everything, I mean, obviously we saw this coming, but things really started to change dramatically roughly the middle of March. Around that time, our governor had closed down the schools. He started to close down the state. There were executive orders about having to send all non-essential staff home. We made the determination that all our staff are essential. Not only is that true, they are obviously all essential, but we also felt that if we deemed those who we were able to send home as non-essential, if we had down the road the need to bring them back and we had labeled them as non-essential, we worried that that might have posed some problems. So all our staff were deemed essential. But that being said, our goal was to transition as many people as possible to work from home. As of today, nearly 60 of our staff are working from home, and that number grows every day because now more and more providers are working from home. This required a huge input from our IT staff, and we have an IT staff of 3 individuals. So this was a huge lift. We did not have enough laptops. We purchased 34 laptops. They each had to be configured. That all happened literally in a matter of 3 days, between a Friday and a Tuesday. The call center was an area of particular concern. Although we moved the call center and spread them out so that they were quite distant socially initially, we did not have the technology to send them home. We talked to our vendor. They kept saying, no, you don't have the right technology. You won't be able to do this from home. And we persisted. And eventually we prevailed, and we were able to send our entire call center home as of the beginning of this week. And it is going great. I'm feeling very, very encouraged by that. As of today, we have furloughed 19 staff. We are committed to continuing the health benefits for all of our furloughed staff. Obviously, that's a significant financial undertaking, but we think that that's critically important. And then we have some of our staff have gone to part-time, namely 8, and that's primarily our dental staff because, like everyone else, dental are doing just emergencies. So we keep one dentist, one dental assistant, and one front desk staff present all the time. They rotate, so basically they're all working part-time. And you see on the slide the pictures of our team. And I have to say, there's been, despite the fact that this has been stressful and without question, a lot of anxiety, I think there's no doubt that it has fostered an incredible amount of camaraderie and friendship amongst people who otherwise really may not have known each other very well before all of this started. So there are some silver linings to this cloud. Next slide, please. It was very clear from the very beginning that we needed to try to stay as connected as possible. And how did we achieve that? Here's some of the ways in which we've done this. Like everybody else, I think, in the country, we were operating on a very limited Zoom platform. We immediately purchased the business platform. This enables us to have a weekly all-staff meeting which is attended by anywhere from 160 to 190 individuals. It allows us to have interactions in that context. And then it's also allowed us to have innumerable Zoom meetings for various purposes, be it executive management team or be it we're actually interviewing candidates. So Zoom was a critical purchase. Instacart became my favorite site. Early on, I wanted to keep our staff well fed, but with fresh food. So we ended up going literally with an every other day order on Instacart. For those of you who've used Instacart, you'll know that you have to order like now 4 or 5 days in advance, but we kept it rolling so that at all of our open sites, every other day, they would get a delivery of fresh fruit. We would couple that with power bars, just a small way of saying thank you and giving people a little lift. Again, this was full fruit. We didn't have cut fruit, so people weren't sitting there taking pieces, and obviously always encouraging social distancing. We always had Skype for Business, but now this became even more critical in terms of real-time conversations between staff who are dispersed through both in sites as well as from at home. And like many others, and like what Kathy spoke about, we actually had sessions run by several different members of our behavioral health team who taught mindfulness and relaxation exercises and continue to do that literally once or twice every week. And lastly, we dismissed the use of the term hazard pay. I just did not like that term, but instead we are providing all of our staff with what we call gratitude bonuses for all of what they're doing. Next slide, please. So like everyone else, we've had to literally turn on a dime. We had to change so many things, and in part of the programs that have grown up through this process, we've also had to redeploy staff. So these are just a few examples of some of those programs. So prior to COVID, we ran a monthly mobile food pantry, which would meet on the 3rd Saturday of every month in the parking lot of a local school. We did this in partnership with the Connecticut Food Bank. And when we last did this in February, over 200 families showed up. Obviously in March, we could not have done that because of the distancing needs. So we worked with the food bank to package food for over 160 families. In March, our staff on the weekend, on their own time, actually delivered all of the food, in some instances 3 and 4 bags of food to these families. But since then, we've partnered with a local taxi company. And next week we will be doing this again with, but with the taxi company doing the deliveries. This is great because it gives our local community, the local workers who are also suffering through all of this from an economic perspective, we're able to support them with some grant funding. It gives them something to do, a sense of purpose, and we're fueling some of our funding dollars into that effort. And in this effort, our director of marketing became one of the key players in this effort. So again, changing from one job description to the next became the norm. Like everyone else, telemedicine, I'm amazed at how quickly we made that transition. Connecticut does not reimburse for telemedicine. So prior to COVID, we had virtually none. We had some asynchronous programs like retinopathy programs and e-consults, but we had no direct audiovisual interactions because there was no mechanism for payment. We are not a managed care state. We are a fee-for-service state. But I can tell you that as of today or yesterday, 86% of all our visits are now being conducted via telehealth or telephonic for those residents who do not have telehealth, do not have internet. We're surprised to learn that many more do than we anticipated, which is a pleasant surprise. We still do some face-to-face visits in some of our sites. One particular site we have cohorted as our wellness site so that all of our well child visits are some of our pregnant women. We try to keep them all at that one location. Obviously, everyone is screened, both staff and patients when they come in with temperatures and a questionnaire. But as part of the telemedicine effort, our MAs were redeployed and they function as translators. And here's another innovation. The telemedicine platform that we turned to did not have the ability to do group visits. So to bring together a clinician as well as an MA who may not be in the same location on a call with a patient was challenging, but our IT team figured out how to do it. So we've done a remarkable transformation in this respect. And then the last program I want to mention is that we established what I would refer to as a command center at a large residential complex. For many years, we have provided services there on a very limited basis, but this is we knew from the very beginning was going to be a very high-risk area. It's over 2,000 elderly and/or disabled residents living in very high densities in 5 high-rises. So we dedicated a phone line. We working very closely with the management company who are providing robocalls, flyers, so that residents know for any issue, be it medical, food needs, what have you, they can call the dedicated phone line. For those residents for whom the clinician determines that the patient is at risk or has symptoms concerning for COVID, an in-home visit is carried out in full PPE and cultures are obtained as appropriate. Virtually every home visit we bring food with us, again, from our partnership with the food bank. And another example of where we had to redeploy staff was care coordinators are now working the front desk for this program, which has really mushroomed. The city of New Haven learned about us and have asked us to do the same thing in 10 additional complexes, which we have started. That project started this past Monday. So we're very busy with this program, but again, trying to meet the needs of the community. And in closing, I just want to say, because this is, I think, my last slide, one of the things that for me that I think has been really an amazing morale booster for our staff and something that we've worked very hard to make sure our staff know about has been the support from our community. We have heard from people and nonprofits we didn't even know existed. Small neighborhood associations have reached out and said, here, we want to give you $2,000. With me recognizing fully that that's probably their entire annual budget. But taking these donations and making our staff aware of every single one has done an amazing job of reinforcing for us why we do what we do and how we are so much a part of the community we serve. So with that, I'll turn it over to you again, Suzanne.
Great. Thank you so much, Suzanne. We really appreciate hearing about all the programs that you guys are deploying in your efforts. And finally, I'm going to turn the microphone over to Stephen Snyder with East Boston Neighborhood Health Center.
Hi, thank you, Suzanne. So I think probably very similar to my co-panelists, you'll see a lot of the same information. I'll probably go quickly through some of the slides that overlap, but there are some things that are unique to the health center here, and we can start with the first slide that we'll go quickly over, but I think we probably share similar missions, and we can head to the second slide, and I'll give you some information about the health center. But we're fairly large for community health center, pretty much, main campus here in East Boston with a couple of the buildings in some of the surrounding towns. You can see on our map here, our service area. We've got over 95,000 patients, over 300,000 visits a year, with an annual revenue of 160 million, 1,200 staff. Our community, 71% live below the 200% of the federal poverty level, and are 70% served best in the languages other than English. Right now, that languages are predominantly Spanish, Portuguese, Italian, and Arabic. For those of you who might be familiar with East Boston, if you've been to the airport, we're geographically isolated with the harbor, and we've got very strong market penetration rates within our service area of the few towns that we predominantly service. We can go on to the next slide. So we've got a variety of services. First and foremost, primary care, adult med, family med, and pediatrics. Women's health, we deliver about 1,000 babies a year over at Boston Medical Center. We took the last couple of years a major effort in integrating behavioral health services, and I'll talk a little bit about that towards the end of our presentation. We have a dental department, and another area that greatly differentiates us from others, and that's been pivotal in this crisis, we do have a 24/7, 365 emergency department, satellite facility, which has obviously been very busy here. We also run a PACE program. For those of you who may be familiar with PACE, it's for a frail elderly population that normally would qualify for nursing level care. We've got close to 700 members in PACE. Of course, that being such a high-risk population, we've been very focused on that. We've got 3 different PACE facilities, one of which actually is much like a nursing home with in-bed services. Additionally, HIV services here, addiction services, very large interpreter services department dealing with 14 different languages, on-site laboratory, 2 pharmacies, radiology, specialties, vision, and nutrition. Pretty much covers our services. Next slide will be fine, thanks. So there's some photos of our buildings. Again, our 2 main primary care facilities are right here in East Boston. We also have a family medicine department in a neighboring town in Winthrop, and our PACE facilities. All in all, it's one freestanding organization. We're probably in about 25 different buildings. Next slide. So again, similar to our co-panelists, I believe it was March 13th that we went into emergency operations planning, where we quickly looked at the various categories that we would need to pay attention to on a daily basis. Sometimes we had morning and evening meetings for some time. Now we've moved to just morning meetings. These are the various categories. My responsibilities are mostly focused on employee relations and communication, although there's certainly a lot of overlap. I also play a role in the community as well. And each member of our VP team here is responsible for these various categories. Next slide. So in terms of employee relations, it was interesting to hear each of us describe the various phases. Our first phase was pretty much dedicated to a lot of staff education, of course, around social distancing and PPE use, and quite a few initial operational changes. Immediately we started looking at HR policies, and we decided in the first couple of weeks that we would be as flexible as we could be. We don't have our time is separated, but we were allowing staff to use vacation time, personal time, sick time. There was such an amount of fear and all the issues around school closings. And we knew we couldn't do that long term, but the initial 2 weeks while we were sort of catching our breaths and doing some planning, we were really flexible. We, unfortunately, we had been inching along with our telecommuting policy over the last year. Like others, that became really critical and went to very wide use of telecommuting. Pretty much anyone who was able to, we wanted them to work from remotely. We really started focusing on staff screening and testing through our employee health department. And I'll give some updates as to where we're at with that. And we started to redeploy staff to key areas. We were very quickly asked by the city to see if we could open a first responder testing site, which we did within 2 days of that ask, which was amazing. And of course, went to front door screeners. Those are 2 areas that we did quite a bit of redeployment right away. And now that we've hit some surges in some of our local towns that we service, we're trying to do the same now in terms of doing some outreach and education in those key communities. So that's sort of what I would describe as phase 1. You can go to the next slide and talk about phase 2. So we started focusing greatly on staff communication and the need, given that everything was moving so fast. We set up a SharePoint site for staff, did some branded emails, given the amount of emails we get every day. We wanted people to make sure that they were paying close attention to our COVID-19 emails. And we went to a town meeting, which has always been something we abandoned years ago because it was just too difficult with so many staff. We've been doing a weekly town meeting, averaging about 600 staff on those town meetings. And we're able to take questions and answers during them, which has been great. We did take a major effort to bring back volume through telemedicine. It's another area that we were not moving very quickly on initially, telemed, and like others, we got into it very quickly. So we, in our first weeks, we saw a drop off of volume close to about 65%, which was very scary, began to ramp up telemedicine. We're now still down, our volume's still down by about 35%, but telemedicine's been pretty successful, and we're just starting to implement video in that process now too, so it's been strictly through the telephone. Unfortunately, we have had to take some staff furloughs. Close to about 10% of our staff are on furlough right now, 115 staff members. It's a very fluid process. We expect that we will continue to furlough staff, and that was really basically staff who literally did not have work to do. It was interesting initially to see people voluntarily want to take furloughs. That could get a little bit complicated, as there were some people that we could not have furlough that were looking to volunteer. But we assume at this point that we're pretty close to done with most of our furloughs, and actually have already brought some staff back on as priorities have shifted. We did do one-on-one communication with human resources via telephone with every staff member who's been furloughed, mostly, of course, benefit questions that we were reviewing, and certainly every way we could support them. We continue to do that. We initially had told staff that we would carry benefits through May 31st and that we would revisit that then. That process has been going pretty smoothly right now. We are definitely paying a lot of attention to that staff. We will desperately need them to come back when it's time for them to come back. We're sort of in that recovery mode now. We designed some specific communications, a separate email system for them, and we have our first town meeting with that group tomorrow. So we plan to continue to focus pretty heavily on that group. Next slide. I wanted to talk a little bit about behavioral health services. Very quickly, most of the behavioral health care staff went to working remotely. It's been one area that's been extremely successful. We're actually at 111% of our baseline, which translates into about 400 visits per week. And we think we'll get to probably about 125%. Most of that reason, there's always been a fairly large no-show rate in behavioral health, pretty common. And I think the fact that people are home now is making it much easier. So the no-show rate is significantly lower. Our BH providers have adapted their visits to include wellness and COVID-19 and social distancing adherence checks. We're going to add, as I mentioned, the video two-way audio-visual component to that too, which will help where we can conduct more evaluations. And so that's been a big success. We know our community depends heavily on behavioral health services, and particularly with this crisis now and the surge of patients experiencing acute anxiety, we need to be there for them. So we're going to continue with that process. Next slide, please. In terms of screening and testing, I wanted to first report on staff. In my role, it's been a huge, obviously, concern of mine. We've had 96 staff tested. There are 5 pending as of today, 17 positives and 74 negatives. We've had quite a few staff recover and come back to work that were either in quarantine or that had tested positive. In Massachusetts, there's been about 122,000 tests conducted, 27,000 cases of positive, and 844 deaths. Within the health center, we've had just over 1,400 patients tested, 551 being negative and 425 being positive. I mentioned earlier our first responder testing site, which initially was designed for first responders in Boston, but now we've opened that up to the surrounding communities and are looking at opening it up now beyond that to patients and particularly workers in grocery stores and things of that nature. That site has tested so far about 170 first responders, and 29 have been positive. Next slide. Just wanted to include some photos from what's been going on here in terms of employee relations. We've been fortunate to have a lot of staff help us in all of our various buildings in terms of communicating with staff. And you can continue to show the next slide. So our staff have actually, it hasn't been easy, but morale's fairly positive. It's been amazing to see various teams come together. These are photos from our first responder testing site. That continues to go strong, and we continue to redeploy staff there. And as it grows, I think we'll be bringing quite a bit of our furlough staff back to help support that effort once we open it up for patients. You can, again, go to the next slide. Like some of my co-panelists, it's been really great to get support from the community. They've been really great about sharing messages with us on social media. We've been working with this one charity called Off Their Plate. If you haven't heard of them, definitely look them up. They've been raising funds so that local restaurants in Boston can support meals for staff. In addition to that, we've probably had 15 local restaurants, and there are so many great ones in East Boston, help us get meals to staff. We've been doing it in a really safe and secure way. We've also had lots of donations of PPE, including some support from New Balance, who retooled their factory. Instead of making sneakers, they're making masks, and that's been really great. So I think that, just that support from the community really keeps the staff going strong. I've had lots of requests for staff who want us to create videos and things of that nature. And taking into account our social distancing, I think we're going to try to do that. We've also been spending a lot of time, in particular our own behavioral health staff have put together some videos around anxiety, and we continue to talk to our staff around wellness as much as we can, again, including our furlough staff. I would say in terms of advice, I think the co-panelists here have done a great job with that. The only thing I would say is that things are moving so fast. I think it's been really hard initially in HR for us to not lose sight of our most important resource, our staff. The families of our staff, the furloughed staff who've been sick. You just cannot pay enough attention to that. We have staff members in HR that are calling staff who've been quarantined or who are sick, a couple of times a week, in addition to contact from employee health. And they really greatly appreciated the staff that have been furloughed have voiced how much they appreciate the constant contact that we've had with them. And I'd say that just from a strictly HR perspective, I think that as much time as you can spend on that, it's going to be worth it, because we know that we're going to desperately need them to get back here and back to work for the flood of patients that will be coming to see us once this passes. So critical. And that's all I've got today. Thank you for listening.
Great, Stephen. Thank you so much. And I couldn't agree more. And I think that the thread of really valuing the workforce, our workforces and health center workforces has really been a theme throughout, and really appreciate all three of you weighing in on all the things that you all are doing at your health centers. And there were definitely some common threads, but really appreciated all the different perspectives. And as all of our health centers are unique in the communities in which they serve, I hope you all will be able to take away, the audience will be able to take away some things that that you can be doing at your health center. So we're going to move now to a Q&A portion here. And I'm going to start out with asking Kathy a question, and the one that came in earlier while she was speaking. So one question that came in, Kathy, is about technology. And so this person asks, how is your health center assisting and training patients with the use of technology?
So this is a good one. So Suzanne had mentioned something about the Zoom license, and like Fairhaven and everyone else, we did not have a Zoom contract. We had an old clunky WebEx, which nobody liked. And so what we had to do was we had to start, number one, we took all the trainings online because there were quite a few free online for Zoom and Microsoft Teams. So they had short videos. Then what we did was we uploaded, we did a recorded session in our Relias program, which is our online learning platform, so that people could just access it. We also, before every single session that we do Zoom, we would give people the idea of how to do chat, how to mute themselves, how to use the bottom of the Zoom program. And then lastly, I tried this last week. Again, things are happening so quickly. I did open office hours for Zoom, and then another one for Microsoft. And that was very interesting. I found that people really need to be in the weeds on some of this technology and just doing it. So that was something that I found really helpful. So we're going to actually repeat every week office hours, and I'm actually learning as I go along. So those were the ways that we were able to do that.
Great, Kathy, thank you so much. And looks like we have a couple questions for Suzanne. So the first one is, are you seeing lower productivity with telemedicine? One person said that they heard calls can go long and therefore lower the productivity.
So that's actually very interesting. We're actually seeing greater productivity, but per provider. They are reporting that it is so much easier to engage the patient in that context. So we're not experiencing that. I mean, providers who may have been seeing, 16, 17 visits a day are now consistently seeing 23, 24 visits a day. There have been some very interesting stories, and I just will quickly share one anecdote. The head of our, Ryan White, our HIV program, reached out to two of her former patients who were always no-showing, never showed. And she knew that they were not on their meds and presumably had, high titers. And much to her surprise, she was able to engage them and it was telemedicine. They were actually able to see each other. And one of them, actually there were two like this. One actually decided to have her interaction in the bottom of her closet. It seems strange, but it made her comfortable. The other gentleman went outside. But the observation from our HIV director was that the lack of a barrier of having to walk into a health center, perhaps maybe with some associated stigma associated to that, made the experience 150% different, and that these were people who she could not engage previously and now had fully engaged them and had plans to re-engage them, soon thereafter. So I think telemedicine has opened up things to us that have been amazing. We've not seen a decrease in productivity on an individual staff basis. We still are not back to our overall health center total numbers, although we're getting there, where it's slowly creeping up. But on a per provider basis, no, just the opposite.
Great, thank you. That's wonderful news. Thank you so much. And then another question for you, Suzanne, around gratitude bonuses. So this person asks, who gets the gratitude bonuses, and do you have any policies and procedures around them?
So that's such a great question, because it did create such a big discussion. How do you make those distinctions? What we ended up doing, we've done it once so far, and we plan to do it again. But the first bonus that we gave, we decided that if in the first, was basically the first 3 weeks of this from the start, that if you were present, you know, if you weren't on, like, we had some people who had been on vacation or had a baby and were out on leave, but if you had a presence in the organization, then you qualified. And then we stratified it in 3 simple ways. The highest, the patient facing, so all of our clinicians, our nurses, our MAs, our front desk staff, anybody who's patient fronting, we paid a top tier. I mean, and these tiers were very close to one another. They were not massively apart. The middle tier were people who worked the full 2 weeks and weren't in that first cohort, who got to go home very early on. And then the last cohort, the lowest tier were folks who worked a few days, but were in the early cohort, who got to go home very early on. And that's how, we sort of backed into it. We decided on that first, and then we created a policy around it, right? So, but it was challenging. I think the next time around, it's going to be easier, because people's roles are much more defined now, right? In those first few weeks, there were people, coming in and out, people being furloughed, people, working from home, not working from home. So I think it's going to be easier, but that's how we decided to do it. We wanted everybody who was working. We're grateful for all of them, and we just made a slight change in the amount of money based on the roles that they play and their presence in the center during that period of time.
Great. Thank you so much, Suzanne. And then we have a couple questions for Stephen, or at least one I see. So Stephen, could you speak to how your teams are tackling absenteeism? Do you have any recommendations or lessons learned when it comes to communicating attendance expectations for staff who work on site?
Sure. From the very get-go, I think we were really clear with our staff about being concise. Initially, because there were a lot of staff without a lot of work to do, it wasn't a critical issue for us. But we needed to really clarify. Again, if people were saying that they did not believe they could get here because of daycare, because of whatever issues they might have, some of it was fear. We would switch to how they would potentially be paid in terms of policies. But we were very clear in saying, for those of you who are, need to be here and are going to continue to be here, the expectation would be that you would be here every day. And thankfully, it really has not been an issue. It's really just amazing to see the staff rise to this level, given that many of them are working in really difficult conditions right now. And we have not really had to come back to it. I think that I've been really, really impressed by that. So I think just making sure that, for people that were on the fence that said, I don't know, if my kid's school is closed and I may or may not be able to get there, we say, well, you know what, then we're gonna have you stay home, and we're gonna not have to wonder about that every day. And thus far, again, we've been able to sort of match the work that needs to get done to the workforce that we've got here. But I think the trip will be continuing to do that, particularly as more volume builds back here. And I think that a question that goes along hand in hand with that keeps coming up is what happens when we want to bring somebody back from furlough, and they might not want to come back from furlough, given that some of them might be actually earning more pay on unemployment. And we know we're probably going to run into that. We hope we don't too often. But once we call somebody back on furlough, they will need to come back to work, or technically they wouldn't be eligible for unemployment anymore. So I think that issue is going to come up at various organizations. Hopefully that answers the question.
I'm so sorry, I was on mute. How has the role, in the interest of time, we have a couple other questions, and if we don't get to them, we will pass them on to our panelists and then send you an email after this session. So, right as I'm asking this question, Mariah is going to launch the evaluation. So if you guys wouldn't mind completing that, that would be great. So Stephen, how has the role of the MA changed in the team-based care environment?
So I think, within the team-based care environment, they're still doing a lot of the work that they were doing before in a much more intense way. And they're being asked to take on added responsibilities. Because of the furloughs, there are less registration staff. So there's just a lot more flexibility. There's even less nursing staff than we had. But mostly I would say it's really redeployment. We've moved quite a few MAs to our first responder testing site. A lot of MAs are doing screening at our front door entrances. And I think a huge undertaking now has been getting volume back via telehealth and going back to reports of patients who had canceled appointments in the early days of this crisis, patients that are looking to schedule appointments. And then the MAs are bearing the brunt of that contact right now in terms of them. So, specific to their teams and their practices. And they're critical. And we're hoping to build some of that volume back so we can get the rest of our MAs back here on a daily basis.
So we had at HRHCare where we had the MAs pretty much in the same line that Stephen is talking about, but we also have had them do chronic care management, the phone calls that are needed, which have really been great. We've had to retrain them, and the training goes on and on. Every week we do some additional training for them, but this has been a way of really keeping everybody working in that role. So that has been another thing we've added.
Fantastic. Thank you guys so much for answering all those questions and for, again, imparting on our audience today all the wonderful things that you're doing at your health centers. We thank you for all that you're doing for your communities and also for imparting your knowledge on everyone joining us today. We did have some questions that we couldn't get to today, and I noticed that a couple of them were not tagged to specific people. So what we'll do is we will get the answers to them and then send them out as a follow-up email. So those of you who are asking questions but didn't have your name associated, will get the answers to those. And I wanted to flag an upcoming webinar that we're doing tomorrow in regards to specifically how dental providers are being engaged during this crisis. So feel free to go to our website and sign up for that webinar tomorrow afternoon. And just stay in touch with us. Feel free to let us know how we can support you. And again, thank you for joining us today. Thank you for all of our presenters for sharing everything that they did. And stay safe, everyone, and take care. We'll talk to you soon.
Thank you all.